patient presented to us a few weeks ago, but it has been months now. He is 64 years old, male diabetic with known history of ischemic heart disease, with the previous PCI to the LAD years ago. He presented with chest pain in another hospital and associated with slight elevation in cardiac enzymes and non-specific ECG changes. The patient did an echo and showed dilated aortic root with an annulus of about 4 centimeter and 6 centimeter sinotubular junction. And angio showed there is an, here, the lady showed an instant restenosis of his previous LAD stent. The X-ray was not so impressive, but we can appreciate some widening of the mediastinum. So aortic root aneurysms are the most common disease affecting the root and the ascending aorta, and it poses as an increased risk for complication not only for dissection and rupture, but also for other cardiovascular events, including MI and stroke. In this paper, discussing the natural history of aortic aneurysm, they found that the incidence of aortic aneurysm is about 5.9 cases per 100,000 person year, and the diagnosis is usually between the ages of 59 and 69. But this is also did not refer to the patient with aneurysmal syndrome. They also found that the transverse diameter of the aneurysm is a major determinant of rupture or dissection, with about 30% risk of rupture or dissection of aneurysm sizing more than 6 centimeters. And the story is a bit different in patient with aortic, with the genetic aneurysm syndrome and connective tissue disorders, like Marfan, Ehlers-Danlos syndrome, Louis-Dietz syndrome, and patient with bicuspid aortic valve, in which the age of presentation and the size cutoff for the rupture is much smaller, sorry. And this was reflected in the guidelines. So the European guidelines recommended intervening on the aortic aneurysm with a maximal diameter of 5 centimeters or more, and even less than 5 in patient with risk factor, compared to 5 centimeters in patient with no elastopathy. So in patient with Marfan syndrome, patient with connective tissue disorder, intervention is at a smaller size and earlier age. And the story is the same for dissection, with extensive involvement of the root should be addressed with composite graft valves or valve sparing root. What I'm discussing here is the surgical techniques. So we shall go for repair or replacement. Arbitrarily speaking, the Pental is considered as a replacement, and the valve sparing are considered as repair techniques. And generally, surgery in the aortic root aneurysm entails resection and the replacement of the aneurysmal tissue with a durable graft. The best surgical technique is a matter of debate. For many years, the gold standard is Pental, which is described by Pental and Di Bono in 1968, was the surgical solution for the root aneurysm, and composed of the replacement of aortic root with a mechanical valve conduit. It underwent several modifications to the original technique, like modification in the coronary reimplantation and also the use for the bioprosthesis instead of the mechanical valve. In this meta-analysis of Pental procedure, the surgical and the late mortality was good. The pooled mortality, operative mortality was 5.6, and late mortality about 2%. But the concern was with the valve-related complication, which reached about 14 to 25% at 10 years. The most common cause of death in patient was low cardiac output, distal aortic dissection, hemorrhage, stroke, and endocarditis, which was a little bit higher in from patient undergoing valve-sparing surgeries. Here in this graph, they are comparing the biological and the mechanical aortic root replacement, and they found there is a slight improvement in the survival with the biological graft, but what was not statistically significant. And this is also the same for embolic stroke, the CNS bleeding, the reoperation, the endocarditis, myocardial infarction, and late mortality. Then Dr. Majdi Yaqub in 1979, he did not want to chop off the normal valve, so he tailored a graft. So basically, he just tailored the graft to and created the 3 sinuses, and transected the aorta, keeping the sinuses, and then sutured it to the ascending aorta, and he reimplanted the coronaries. In the original description, the annulus was not supported, and this has raised some concern regarding the increased risk of later AI in young patients with connective tissue disorders. Then in the following years, Tyrone David, 1992, he invented his reimplantation technique when the whole aortic valve is implanted within a Dacron, with the Dacron graft. By this way, he involved the annulus, and this is considered as the support of the annular tissue. And it makes it more suitable for young patients with annular dilatation or connective tissue disorder. It underwent multiple modifications. Finally, with David 5, with larger graft to improve the flow hemodynamics. So I did not explain this when I presented, but for some we were discussing between us. First, he did the reimplantation. David 1 was the implantation with the used a 26 to 30 millimeter cylindrical tube graft, and resected the sinuses, and he reimplanted the whole valve into the Dacron graft. Then in David 2, which also is similar as Yaqub, he did the fashioned graft and sutured it to the ascending aorta, and they have the same problem as annular dilatation in patients with Marfan. And then he added the ring in the David 3, added the ring to support the annulus. Then he found that the hemodynamics was superior in patients with remodeling. So he wants to create a new sinuses, and so he used a larger graft and plicated it proximally to create a sinuses, and this improved the hemodynamics. So he even go to a larger tube graft by 6 to 8 millimeter, and plicating the graft from proximal and distal to create a new sinuses, and showed some improvement of the hemodynamics. People in Stanford, they simplified this plication, and they used 2 grafts, larger graft here to create the sinuses, and smaller graft suture to it to be attached to the ascending aorta. When we see the papers describing the results from this operation, it was quite good. Yaqub for freedom from the operation and freedom from moderate to severe AI at 10 years was 89% and 64% respectively. And this was in the era where there is no ring. And then reimplantation by David, 98% freedom from operation and 93% freedom from moderate to severe AI. And this is only reported by David. By others, it is still good, but is less than the David. Here, after the people from Montreal, Lanzac, and et al. They used the ring annuloplasty in addition to remodeling and converted to reimplantation by David. And they found that 7 years, the freedom from aortic reintervention was similar between the group, and also the amount, the recurrence of severe or moderate to severe AR was similar between the two groups. So multiple studies try to compare these techniques, no randomized trial, only meta-analysis and retrospective studies. So which way to go? We will go through this meta-analysis, which was published in August 2019 in London, comparing the outcome between the different surgical techniques. It comprises more than 30 studies and about 7,000 patients. They found that the operative mortality is significantly lower in valve-sparing root replacement with an odds ratio of 0.51 and p-value of less than 0.05, despite the longer cardiopulmonary bypass and cross-clamp time. And they also found that the 5-year survival was also more favorable in valve-sparing root replacement group. But in subgroup analysis, there was no survival difference in patients with aortic dissection. So the 5-year survival benefit was the pooled patient from all etiologies. When they sub-analyzed it, in patients with aortic dissection, there was no difference in 5-year survival. There was longer duration of cross-clamp time and operative time in patients with valve-sparing root replacement, longer hospital stay in Bintal group, there is a significantly lower rate of cerebral thromboembolism and incidence of heart block in the valve-sparing root replacement, and it is also statistically significant. The rate of the operation, there was a trend toward increased reoperation in the valve-sparing root replacement group, but it does not reach the statistical significance. And also when they analyzed Marfan syndrome, they found that reoperation rate favored the Bintal patient cohort. And also it was not statistically significant. In this same meta-analysis, they tried to study the influence of covariate and main outcome, means that the patient characteristics that affect the survival or the development of later AR. They only found that the use of mechanical valve was associated with increased operative mortality, but was not statistically significant. And for the late long-term survival, the age is the only positive predictor for long-term survival. Female gender, Marfan syndrome, aortic dissection, and other covariate was not associated with improved or decreased long-term survival. It was not statistically significant. So they concluded that the valve-sparing root replacement should be considered as the first-line option for root aneurysms in patients with repairable aortic valve. In another meta-analysis from Ontario, also they are comparing the root replacement versus the composite valve graft procedure in management of aortic root dilatation. They also did not, in the early outcome, there was only some difference in the bleeding and for the late outcome, difference on mortality, which there was no difference, sorry, in bleeding or mortality in the early and the late outcomes of surgery. Here in a paper from China by Boyang and et al., they published their experience with acute type aortic dissection, 20 years experience, and they concluded that the aortic root replacement and aortic root repair are appropriate surgical option for patients with aortic dissection with favorable short and long-term outcomes for both cohorts. And they found that the aortic root replacement should be done in patients with aortic dissection with an intimal tear passing the aortic root, root aneurysm, which is very large, more than 4 by 5 centimeter, connective tissue disorder, or unrepairable aortic valve pathology. And here in this study also they are comparing the valve sparing in patient with bicuspid and patient with the tricuspid aortic valve. And they found that if it is done by an experienced surgeon, there was no difference in the 10 years survival between the patient with tricuspid and bicuspid aortic valve. Back now to our patient, the patient through medial sternotomy, they did CABG for him off pump, followed then by an aortic root replacement with mechanical valve conduit. He was weaned smoothly from the cardiopulmonary bypass. The intraoperative echo showed there is no regional wall abnormality and patent the coronary potence, and the ICU was hemodynamic stable, though there is a high chest tube output. He was re-export for bleeding that night, and he received a massive amount of blood products. Fortunately, he was able to extubate him in the morning, and he was discharged home on the 6th post-operative day on warfarin. In short, the randomized controlled trial comparing the outcome of surgical techniques are lacking, and the ultimate surgical technique should provide durable and reducible solution and lower rate of complication and reintervention. Valve sparing and composite graft replacement provide a durable and favorable result in patients with aortic root disease. Valve sparing option may be more favorable in younger patients with favorable valve anatomy. Valve sparing option may be associated with lower mortality and late complication, and may be considered the first-line treatment in patients with aortic root disease and normal valve in experienced hand. The choice of between valve sparing intervention and composite graft with valve prosthesis depends on multiple factors, including the analysis of the valve function and the anatomy, the size of the aneurysm, the life expectancy, the desired anticoagulation status, and the experience with the surgical team. Thank you very much.
Thank you, Dr. Othman.
Thank you very much.
Thank you.
So first choice we have to go is a Bental, unless you are experienced.
تسأل ولا تقول يا هيثم؟
لا بسأل عثمان أنا.
عثمان؟
Just 1 second. And most of the data here are coming from Experience Center, from David, from Lanzac. People from low volume center usually have not worse, but lower successful rate from valve sparing root replacement in patients with aortic root aneurysms.
But how come, yani, if my findings suggest in the operation that I have to do Bental, then I have to choose Bental. Yani, it doesn't. Yani, my question, yani, how come that I will find that the valve is involved and I will do valve sparing? So I mean, no operation is superior to the another. It depends on my findings.
I didn't get your question.
It depends on your findings, but from their findings, from meta-analysis, they find it is superior, and there is no valve that cannot be. Most of the valve that can be repaired, and even if the valve was repaired, they have a result that is better or comparable with the classic Bental. And these patients, they survive better and they go back to their life doing even competitive sports compared to patients with Bental only.
Okay.
Doctora, usually in case of dilated root, the valve structure will be normal, but the annular will lead to the regurg.
Okay.
So the idea to decrease the annular size. But if you don't have the luxury of doing the procedure which decrease the annular size, you just replace everything.
Oh yeah. So I will try first then.
No.
If I can.
No, you will not try. If you train to do one of the procedure to preserve the valve, it's better to do. If you don't, if you are not trained to do, don't waste your time to trying. Just replace everything with Bental.
Oh yeah. Okay.
Or you go and do valve sparing by David, which is, and also need to be trained to do that. Instead of doing, you have either reimplantation or remodeling. Reimplantation, that's mean David. Remodeling, it's mean Yaqub, which showed it is better in hemodynamics, but you need to address the annulus of the aortic valve. Before going to, you need to go to read about Khoury classification to understand. In Khoury classification, it is functional classification of the AI. So there's 3 types. Either you have type 1, which is normal, the leaflet is normal. Then type 2, which is prolapse leaflet. Type 3 is restricted leaflet. And under type 1, you have sub type A, B, C, and D. Type 3, forget it. Restricted, you will not repair it. It is difficult to repair if you have severe restricted, right, in case of rheumatic heart disease. But usually, AI, you can repair it. What's the difference between remodeling or reimplantation? Reimplantation, you address the root, you address the root, you address the annulus, okay, in the David. Yaqub, remodeling, you leave the tongue. So that area is prone to dilate, especially in patients with connective tissue disease, okay? And this is why Othman was saying you need to address the annulus. The annulus is addressed by David because you are not doing anything. Other thing, in your exam, anyone asks you, you said Bental. Once you said I will do valve sparing, you dig a hole. Exactly, you dig your grave.
Yeah.
If they ask you, okay, you said, okay, this, for example, they give you an aneurysmal patient, blah, 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 okay. You said, I will go and do for him Bental because I know how to do the Bental procedure. They will ask you, okay, do you have any other procedure? Yes, I have, but I'm not expert to do valve sparing. This patient is good candidate for valve sparing, but I'm not expert. I will go and do Bental, full stop.
Yes.
What do you think, Hussein?
Yes.
Othman?
Othman?
I think...
Masha?
Any further question, Dr. Ayat?
Thank you. يعطيكم العافية.
Othman?
From anybody else?
Othman موجود ولا خلاص؟
I think he's busy.
موجود بس انه شكله ما يتحدث.
You have any question? Hussein?
Yeah, I have one question بس إذا مو موجود فخلاص. الله يعطيكم العافية.
موجود.
Othman, did you find any difference between in the literature, any difference between mechanical or biological Bental?
In the paper that I put it there, they compared the biological and the mechanical. They found there is a trend toward better survival, and with biological.
Okay.
And also trend with lower thromboembolic complication, but it was not significant, clinically, statistically significant.
Okay. And what about the idea of taking more time on bump to restrict to constrict the biobental? Because we don't have ready-made biopental. We have to do it on pump because you have to size before, right? So you will take 20 minutes.
Yeah.
So that will increase 30 days mortality, or
I did not read this specifically, but they in taking longer cross-clamp time and cardiopulmonary bypass time, reaching up to 500 minutes in some patients. In patients with valve-sparing route, they found there is no association with increased complication or mortality. But with regard to biological and mechanical, I did not come across that.
طيب one more question.
حسين معليش بس لانه ريليتد للكويستشن حقك اذا تسمح لي. طب في احد منكم شاف تسلم احد شاف البيولوجيكال بنتال؟
Yes, me.
Yes.
Actually, Hussein, I have answered. 1 second. I have answered to this. Usually, you have your assistant, you have another assistant. So usually, the second assistant, he will fix the valve to the conduit.
طيب وش كان الانديكيشن in those cases؟ ليش يعني اختاروا بيولوجيكال؟
simple indication يا فيصل. الحالة اللي شفتها old age and he want to old age. اسمع السيناريو. old age, the surgeon want to avoid high dose of warfarin. المريض كان عنده AFib. and حط له biological. طبعا كل الناس قالت انه why biological وهو already على warfarin. بعد شهر المريض جل ER بهيموغلوبين 5 عنده severe GI
mechanical and no one will fault you because the data they showing no difference between the two cohorts.
Totally agree.
So the show is it is a case by case. If it's not our you can talk to the patient and see his wishes. Even some of the papers saying that if you don't have a valve sparing surgeon, it's better to consult or transfer that patient there, and there he can choose from valve sparing and pental procedure.
Another patient Faisal was 70 years old من أقل من شهر 70 years old with borderline ejection fraction. وجهة نظر السيرجن كانت he will not waste 20 minutes suturing tissue valve to conduit. So this patient will not tolerate. His high risk, he will not tolerate. It's better to put biopental, safe 20 minutes, get the patient live, better than doing perfect procedure with borderline patient.
كيف you will save time؟ انت بالعكس كذا يمكن take longer بالباي procedure.
لا حط له بنتال.
I see. ايوه mechanical. اوكي.
Pental can be mechanical or bioprosthesis.
شلون؟
Pental can be mechanical or bioprosthesis.
اي بس المشكلة عثمان في السعودية إلى الآن ما في بايوبروستيتيك جاهز.
اغلبهم يستخدموا تحط السوتشرز في تاخذ فالف وتسوي له سوتشر في الجرافت وتعمل له امبلانتيشن.
بالضبط، بس عشان تسوي هذه البروسيجر لازم المريض يكون على كارديوبلمونري باي باس، تفتح الايورتا، تقيس الايورتيك فالف اول، بعدين تسوي تحط الايورتيك فالف داخل الكندوي وتخيطه. يعني ما تقدر تسويها قبل العمليه والمريض لسه مو على كارديوبلمونري باي باس. فهمت قصدي؟
نعم.
طيب عثمان، الهوموجرافت it's not an option in this patient.
Homograft it's an option, and they consider it from the replacement as and they are comparing it with bioprosthesis pental.
Okay.
So it is the same issues. The only issue is with the operation is the increased. It will be a hell with during reoperating. If you are doing sternotomy and you need to address the valve.
Okay. And freestyle?
Freestyle, Ross, whatever.
هذه كلها للروت صح؟
كلها للروت.
One issue with Ross is that if patient with Mulhim or patient like bicuspid aortic valve, you have to examine. I have to be very meticulous in doing Ross because the abnormality might also affecting the pulmonary. So you have to be very meticulous. If you can do it, طبعا.
طيب عثمان ايش الديزيزز اللي I cannot do يعقوب and it's better to do David?
There is no such thing. This meta-analysis included all aspects. They included patient from. They included patient with aortic dissection or patient with infective endocarditis, patient with Marfan, patient with Lewis syndrome. All type of patient were included in this meta-analysis, and they found that if the valve is repairable, it is done by experienced surgeon, we can do whatever procedure you want.
الله يعطيك العافية يا رب. Excellent presentation. Thank you.
Thank you, Othman, very much. Kindly, could you please go to the